Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 3 of the basic dermatology curriculum organized by the Saudi Society of Dermatology and Dermatologic Surgery. Thank you for joining us today. So this session is being recorded and will be made publicly available along the course content on the Society's official platforms on social media at Derm Club. So today's session plan will include the main lecture delivered by Dr. Hessah, followed by a 5-minute scientific talk by L'Oreal, and then we will have also a 5-minute or 10-minute Q&A session. So please feel free to type your questions in the chat at any time. We will go over them with Dr. Hessah. So the session today will be delivered by Dr. Hessah BinJadeed. She's a double board certified dermatologist, and she has fellowships in complex dermatology, research, and pediatric dermatology. Thank you very much, Dr. Hessah. It's a pleasure and honor to have you with us today.
Assalamu alaikum. Thank you for inviting me. I'm excited to talk about today the drug reaction and then the urticaria. We will make it simple and we will highlight the most important points about both disease. So to start with the drug reactions, our learning objectives for the drug reaction is to identify the morphology of common and serious eruption. Most importantly, to identify the red flags, initial management principle, and when to consider referral to dermatology or ICU. So the main principle in evaluating drug eruption, usually the diagnosis is clinically based on morphology and the timing of drug intake. No need usually for biopsy, and we may consider it in some cases. Always ask about a drug if you are considering drug eruptions. Ask multiple times in different occasions. Usually patients forget about the medication that they take, so it's important to ask them multiple times if the drug eruption in your if you are considering drug eruptions, especially those that they are taking on intermittent basis, including non-steroidal anti-inflammatory drugs. So after establishing the diagnosis of a drug eruption, don't forget to mark the patient is allergic to the caliper drug. And of course, you have to know the type of reaction. Some medication have a cross-reactivity and severe drug reaction, so you have to avoid them all. Like an anticonvulsant, fenobarbital, carbamazepine, phenytoin, all cross-react. So you have to avoid, if the patient is allergic to one of them, you have to avoid them all. However, valproic acid and lamotrigine consider a safe alternative. The same with sulfonamides, the antibiotic. If the patient is allergic to one of them, you have to avoid all. So the highest risk medication, you suspect that the patient is having drug reaction if he is taking antibiotics, anticonvulsant, antipsychotic, allopurinol, trimethoprim, sulfamethoxazole, especially in those who have HIV. So in a patient with HIV who is taking trimethoprim, sulfamethoxazole, 40 of them will develop drug reaction. One of the most common medications that used, which is the non-steroidal anti-inflammatory drugs, can also cause drug reaction. And as I mentioned, you have to ask the patient about any of those that are they are taking in intermittent basis. So we have different type of drug reaction. We have the most common subtype, which is the morbilliform drug eruption. I'm sure you have seen one. And then fixed drug eruption. We will elaborate more and discuss it more. What is it exactly? Then drug-induced hypersensitivity syndrome, or drug reaction with eosinophilia and systemic symptoms. From the name, we can guess that it has some systemic symptoms. Then the most life-threatening drug reaction, which is Stevens-Johnson syndrome or toxic epidermolysis necrosis, depend on the body surface area involved. So we can divide the drug reaction into simple, those that they don't have visceral or systemic involvement, then severe systemic involvement. Only 2% of all cutaneous drug eruption are severe cutaneous adverse reaction. We call them SCARs, like the Stevens-Johnson, TN, stress, AGIP, anaphylaxis, and anticoagulant-induced skin necrosis, and generalized fixed drug eruption. So what are the clinical features that suggest that the patient is having severe reaction? So this is a very important slide. You have to ask about those questions when you suspect a patient with drug reaction, even if the patient is having mild morbilliform rash, you have to look for those. So first of all, skin pain. If the patient presented with a skin pain, this is an alarming sign, which could indicate Stevens-Johnson or TN, confluent erythema, very diffuse erythema. This is also an alarming sign. Facial edema, we can see this in a dress. Blisters or epidermal detachment. This is also seen in a dress or Stevens-Johnson or TN. Mucosal erosion is also a bad sign. Necrosis, palpable purpura, always when a patient comes with a drug rash, palpate the lesion. Look if it's plungeable or non-plungeable. Is it painful? Patient with TN and Stevens-Johnson syndrome will have tenderness upon palpation, swelling of the lips or tongue, which is a sign of anaphylaxis. Then ask in the history, does the patient have a fever? Take a vital sign, palpate for lymphoadenopathy. If the patient have lymphoadenopathy, this is a sign for redress. Arthralgia, arthritis, this is a sign seen in vasculitis, shortness of breath, wheezing, stridor, this is a sign of anaphylaxis. Hypotension, also a sign of anaphylaxis. Other visceral organ involvement, we can see it with a dress. So, if a patient presented to you, you have also to order a labs, which usually CPC with differential and liver enzyme and renal. To look for what? To look for leukopenia. This is a bad sign if a patient have a leukopenia. If the patient have thrombocytosis, this is also a bad sign. If the patient has increase in eosinophils, especially if high number of eosinophils, this is a bad sign seen in a dress. We can see a mild elevation in eosinophils and morbilliform rash, but if it's a high number, this is not acceptable. Usually this is a severe reaction to the drug. Lymphocyte with atypical lymphocyte, we will see the typical lymphocyte with the peripheral blood smear. And then also we can see elevation in liver enzyme and renal function test. So this is the most important thing that we have to look in our examination, in our history, and then to order the labs. So we'll start with our first case. This is a 34-year-old woman developed diffuse, itchy, symmetrical, blanchable, erythematous patch starting on the trunk and then spread to the limb. She also has sinusitis, for which she is taking amoxicillin and claviculinic acid. Augmentin started 7 days ago. She has no facial involvement, no mucosal lesion, no fever or other systemic symptoms. Vitally, she is fine and her labs are normal. I'll give you a few seconds to think about it. So we mentioned that she took antibiotics 7 days ago, and she presented with this symmetrical itchy plungeable erythema that start in the trunk, then spread to the limbs, and she doesn't have any red flags, no facial involvement, no mucosal lesion, no fever or other systemic symptoms, and she's vitally stable and her labs are okay. So this is the most common drug reaction, which is the morbilliform drug eruption. Usually it starts 7 to 14 days after a drug intake. Rash usually start with plungeable erythema. Usually in the lower limb, we can see that it's purpuric. However, we can differentiate it from vasculitis, that it's usually non-palpable. As we mentioned, that palpable purpura is an alarming sign. So in if you saw a patient with purpura in the lower limb that it's not palpable and he has blanchable erythema elsewhere, this is fine because usually the demented area, they will develop a purpuric region. Usually start in the trunk and then spread to the extremities. We don't see mucosal membrane involvement in contrast to Stevens-Johnson and TAN. Usually the patient will have pruritus in contrast to the viral exanthem. Usually they don't have itchiness, no pain. Pain in the skin is an early sign to Stevens-Johnson and TAN. Patient may have low-grade fever. The eruption usually subside 1 to 2 weeks after stopping the drug. Some cases may have exfoliation and desquamation after the rash subside, and usually this is where we receive another call from the primary team to ask, is this Stevens-Johnson or not? They get scared when they see the exfoliation or desquamation. Usually in this case, I will show you a picture of exfoliation and desquamation, and we will highlight how to differentiate between it and from Stevens-Johnson and TN. Do we need biopsy in this case? No, usually it's a clinical diagnosis. We don't need biopsy. So this is a picture of the exfoliation or desquamation. Usually we can see it's only epidermal desquamation. We see mild erythema. Usually when you palpate this erythema, it's blanchable. There is a patient who looks well. The patient doesn't have duskiness, which is a dark red or a purpuric lesion or a very purple discoloration in Stevens-Johnson. So the erythema is mild, blanchable, and the scale is epidermal. We don't see sloughing. We don't see severe erosion. So this is usually following the morbilliform rash. So the treatment, should we stop the caliper drug? Usually, no. If it's essential to the patient, if the reaction is mild, and we can treat through. However, if it's antibiotic and it's not essential to the patient, and if the case is severe, we have to stop. So we agree that if it's essential and mild reaction, we can treat through. And usually it's very rare to transfer or progress to Stevens-Johnson TN. Supportive care usually is enough. If the patient is symptomatic, having itchiness, we can give medium to potent topical steroid, PID for 2 weeks, or antihistamines. Then moving to our second case, this is a 29 years old man developed single, well-defined round erythematous patch on his thigh that became dusky and painful within hours of taking ibuprofen. For headache, he reports the same lesion appearing in the exact location during past episode after taking the same medication. No fever or systemic symptoms. So the clinical clue here, we have single, well-defined, round, erythematous patch. I'm not sure if I can see. Okay, great. We have answers here. So fixed drug eruption. So usually fixed drug eruption, it's a recurrent episode of one or a few well-defined, round over red to violaceous patch becomes, sometimes it will become a blister. Lesion, the clinical hint here is that the lesion reoccur at the same site each time the drug is taken. Common site usually in oral and genital region, but can occur anywhere in the body. Usually it's asymptomatic, but may be itchy or painful. Patient remains systemically well, so usually they will not become ill or they will be very well. Lesions heal with prompt post-inflammatory hyperpigmentation. So sometimes we will see it in the clinic. Patient will present with a very well-defined pigmented lesion, and it will persist there, and he would say that I had like erythema before or something. And any round lesion, round hyperpigmented lesion, suspect that the patient is having fixed tract eruption. But usually the patient will present with duskiness at the beginning and leaving hyperpigmentation after resolving. So do we need biopsy? Usually no, it's a clinical. Biopsy needed if not clear. As I mentioned, that if the patient presents with post-inflammatory hyperpigmentation only, sometimes it's difficult to diagnose, and usually we will need biopsy to confirm the diagnosis. So as we mentioned, patient will present with duskiness, purple color that he might also develop blister. And one of the common location is the lips. So this the patient present with only post-inflammatory hyperpigmentation, which is also called the pigmented variant of fixed tract eruption. So what is the treatment? Should we stop the calorie drug? Yes, otherwise it will reoccur. We have different subtypes, the non-eroded, similar to this, or here, without this one. So we will treat with medium to high potency topical steroid, BID for 2 weeks in the body, and consider low potent topical steroid if it's in the face or the fold. For eroded fixed tract eruption, we will treat it with dressing and wound care with antimicrobial ointment and dressing until healing. If it's generalized, refer to the patient to the dermatology. If it's generalized full-less fixed tract eruption, you have to admit the patient in the burn or ICU unit. Next case, 42 years old woman present with widespread morbilliform rash with facial edema and fever 2 weeks after starting carbamazepine for trigeminal neuralgia. She reports fatigue, and upon examination, she has lymphadenopathy. Labs shows eosinophilia, high LFTs, and mild renal impairment. No mucosal erosion are noted. So what is the expected diagnosis? Not sure if someone is answering. Okay, so I can see some answers. Dress, correct. So the clinical hints for dress usually start 2 to 8 weeks after drug intake. So it's a delayed reaction, usually after 2 to 8 weeks, unlike the morbilliform rash that started within 7 to 14 days, or Steven Johnson. Sometimes even Steven Johnson starts late, but usually a dress is a delayed reaction. Usually the rash starts on the face and then spread to the trunk, compared to the regular morbilliform rash, usually start in the trunk, then spread to the extremities without facial involvement. Here in dress, we have facial involvement, we have facial swelling. The patient will present with systemic symptoms. They will have fever, lymphadenopathy, hepatosplenomegaly. So always palpate the lymph nodes and look for hepatosplenomegaly. So in your CPC, you would see eosinophilia, and your peripheral blood smear, you would see atypical lymphocyte. So you might also have high LFTs, impairment in the kidney, which is a common involvement in drug and address. Heart and thyroid involvement usually late sequelae to the address. Symptoms may continue for years, for weeks or even months, despite drug withdrawal. So you have to arrange for long-term follow-up. So should we stop the caliper drug? Yes, stop all suspect medication and non-essential medication. This is a serious drug reaction. Advise the patient to avoid the offending drug. Document the allergy in the medical record. As I mentioned, some medication would have cross-reactivity, so avoid all. So a part of your management is to order the labs, especially in the acute phase. So as we mentioned, CBC with differential, platelet count, peripheral blood smear for atypical lymphocyte, renal function test, and urine analysis, and liver function test. Those labs you have to repeat twice weekly in your acute phase to document the progression. And then thyroid function test and TSH as a baseline, and then repeat at 3 months and then 1 year and 2 years. Why? Because stress will lead to thyroid disease as a delayed sequelae or late sequelae. Also order fasting glucose, because usually if the reaction is severe, we will start the patient on systemic steroid. Then based on your presentation, you will order further testing like ECG, troponin, echo if the patient have cardiac symptoms, brain MRI if the patient have neurological symptoms, chest X-ray, pulmonary function test if the patient have pulmonary symptoms. So as you see, it's a serious reaction. If the patient presented with facial edema or abnormal labs, you have to suspect DRESS. So what should you do? You should hospitalize the patient with moderate to severe cases, consult dermatology and other specialty based on organ involvement. In mild cases, we can use potent topical steroid, also taper over 6 to 3 months. Usually you taper slowly, unlike the other. Severe cases, we have to use systemic steroid, prednisolone 1 to 2 milligram per kg per day. And also we have to taper slowly over 4 to 6 weeks to 3 months. Okay. So, summary. So the clinical clue is morbilliform rash with facial edema, fever, lymphadenopathy, systemic symptoms, or any new drug exposure. Recommendation or recommended investigation. So we'll do CBC with differential to check for eosinophilia, atypical lymphocyte, liver function test, renal function, and strongly consider urine analysis, TSH, echocardiogram if cardiac involvement is suspected. So moving to the most serious and important drug reaction. This is a 28-year-old woman developed painful erythematous macule and sarcoidoid lesion in her trunk and face, which rapidly progressed to blister and epidermal detachment. She also has painful erosion in oral cavity and lips. Symptoms began 10 days after starting allopurinol for hyperuremia. She reports fever and malaise, but no prior similar reaction. So what do you think? Okay, great. So Steven Johnson or TN. So it's a life-threatening mucocutaneous reaction. Steven Johnson, usually we would say Steven Johnson or TN based on the body surface involvement. Steven Johnson less than 10%. Steven Johnson TN overlap, which is 10 to 30, and TN more than 30% of body surface area. Usually start 1 to 3 weeks after drug intake. The patient would present with prodrome flu-like illness lasting several days. Unfortunately, this is mistaken with viral exanthem. So if a patient presented to you with a prodrome, flu-like symptoms and a rash, then suspect that the patient has a drug eruption. Even if the patient has a flu-like symptoms, and keep follow the patient, especially if elderly patient. Usually the viral exanthem, we would see it more in pediatric. In adult, rarely we see the viral exanthem. In adult, if we see diffuse erythema, suspect that the patient is having drug reaction, even if he has flu-like symptoms. So usually the patient present with abrupt onset of tender, painful, dusky erythema starting on the trunk, spreading rapidly to the face and limb, progress to flaccid blister, merge into sheet of skin detachment. Erosions in the mucosal membrane, including the eye, nose, mouth, lips, and genitalia. So we have to look for all mucosal membrane when we examine a patient with suspected drug reaction. Even if it's a simple drug reaction, we have to examine all mucosal membrane to rule out Steven Johnson and TN. Sometimes we will not see any erosion, but the patient might report pain while swallowing. This means that the patient is having erosion in the esophagus or the throat. And then patient might have also painful urination, so ask in your history. The patient usually is unwell and ill-looking, and the patient in pain. Patient will have positive Nikolsky. Nikolsky, when you rub the area of redness, the a blister or erosion would appear. Usually we avoid to do that an extensive area because this is very harmful to the patient. It's painful and you increase the risk of infection. So we have to palpate the skin. We have to rub it, but only do it for a small area. Don't repeat doing that in multiple areas. What should we do? We have to stop all suspected medication and non-essential medications because multiple medications also is a risk factor to develop Stevens-Johnson and TAN. The faster the offending drug is discontinued, the more favorable the prognosis. So if you receive a consultation overnight and telling you that the patient is suspected to have a Stevens-Johnson or TN, the first thing that you have to do before any management is to stop any suspected medication because this will affect the prognosis and the outcome of the disease. You have to hospitalize to burn unit or ICU, immediately consult dermatology and other specialty based on the presentation of ophthalmology if the patient have ocular involvement, gynecology or urology if the patient has genital involvement. Supportive therapy in a burn unit or intensive care unit is the ministry of the treatment. So supportive care is more important than active therapy. It is the most important part in the management of Stevens-Johnson and TAN. That's why we have to admit the patient into a burn unit or ICU. So first, we have to take a good wound care with non-adhesive petroleum paste dressing and avoid silver paste dressing. Why? Because the sulfa can cross-react and induce Stevens-Johnson and TAN. It's one of the culprit drug. We have to monitor for input and output and watch for the fluids and electrolytes and replace any loss. So we'll manage the patient as a burn patient. We have to provide nutritional support. We have to put the temperature, keep the room temperature in 30 to 32 Celsius. We have to monitor for infection because of high risk of sepsis, and this is the most common cause of death in a patient with Stevens-Johnson and TAN. So we have to perform regular pan culture. We will take swabs from the skin, blood, urine, and any other line. Prophylactic systemic antibiotic usually is not recommended, and as we said, stop any unnecessary medication. Then oral care. Use oral antiseptic and lidocaine rinse and intraoral superpotent steroid. Usually what we have in the hospitals is the magic mouthwash, so we can use that. Ocular care, we have to consult ophthalmology in all patients. Even if we do not see a clear conjunctivitis, we have to consult them. And we have to place the patient on lubricant. Genital care, if the patient is a female, we have to consult gynecology and for consideration of vaginal dilator and to place the patient on topical steroid and Vaseline. For male patient, also we can apply Vaseline and consult urology. General supportive measurement other than what we mentioned, we have to put the patient on VTE prophylactic with low molecular weight heparin, PPI for GI ulcer prophylactic as needed for the stress ulcer. So also close monitor for respiratory failure. The active treatment, so as we mentioned, the most important part is the supportive care. We can place the patient on other therapy. We have different things that we can use. One of them is the corticosteroid. The evidence is mixed and benefit most likely in early inflammatory phase. So the patient, if presented after 24 hours of stuffing, usually they will not benefit from the corticosteroid. In a recent review in 2021, they combined steroid with IVIG. They said it might reduce the mortality in Stevens-Johnson and TN. Usually, we use cyclosporin. The dose usually is 3 to 5 milligram per kg per day divided into BID. It has a promising efficacy. IVIG, it's usually the data is inconclusive, no consistent mortality benefit, and usually the physician would be afraid because of risk factors of renal failure, anaphylaxis, coagulopathy, or aseptic meningitis. The other treatment method is the etanercept. Most of the doctors, they like the etanercept because it's a single dose, 50 milligrams sub-Q, and usually the patient will have a good response. So we have 4 options: corticosteroid, cyclosporin, IVIG, or etanercept. That's corticosteroid and IVIG, usually unpreferable treatment because the evidence is mixed between them. And preferable treatment is cyclosporin or etanercept. So the take-home message: a detailed medication history is essential in suspected drug reaction. Be sure to document the drug reaction in a patient's chart with the medication and description of the reaction. Xanthomatous eruption are the most or multiform drug reaction. It's the most common of all cutaneous drug eruption and tend to resolve without sequelae. Patient feel well and the rash may be itchy. Fixed drug eruption will reoccur at the same place with re-exposure to the drug. Breast cutaneous drug eruption with facial involvement, edema, patient may be febrile and feel unwell. Check LFTs, CBC, creatinine, and PON. Delayed systemic involvement may occur in breast many weeks even after cessation of the offending medication. So long follow-up is required, especially the thyroid and heart. Stevens-Johnson and TN are acute, life-threatening mucocutaneous reaction characterized by dusky, painful rash, evolve to blister, and skin detachment with mucosal membrane involvement. So stop offending drug immediately or consider or concern for Stevens-Johnson and TN. Thank you, everyone. Okay, so to the second part of the lecture, which is the urticaria. So our learning objective is to identify the clinical morphology of urticaria and recognize and differentiate the various types of urticaria, and then outline the initial diagnostic workup and review the treatment approach. So about the basics of urticaria, So urticaria hives is a vascular reaction of the skin characterized by wheals surrounding by red, hado, or flare area of erythema. Urticaria is caused by swelling of the upper dermis. That's why we see in differentiation to other rash, we would see swelling, which is a characteristic of urticaria. The cardinal symptoms is pruritus. Patient will present with itchiness. The individual lesion usually lasts less than 24 hours without any hyperpigmentation, and compared to urticaria vasculitis, which is usually lasts more than 24 hours, leaving hyperpigmentation or pose-like. So just to clarify this point, usually the patient would be confused. What's the meaning of how long does the lesion last? Easier way to simplify it for them: if you circle one of the lesion, would it last for a day or no, it will move to another area? So usually urticaria patient, they would say no, I mark one lesion, usually it will resolve within 24 hours without any sequelae, without any hyperpigmentation or prose-like. Up to 20% of population, usually they have urticaria at some point in their lives. So we classify urticaria based on the duration to acute or chronic. If the patient having recurrent episodes less than 6 weeks and usually 1 week in acute urticaria, we classify it to acute urticaria. If it's last more than 6 weeks, usually this is chronic urticaria. And then chronic urticaria further divided into spontaneous or inducible. Inducible, we have different subtypes: dermatographism, cold urticaria, cholinergic contact urticaria, delayed pressure urticaria, solar urticaria, heat urticaria, vibration urticaria, or aquagenic urticaria. From the name, we can guess the cause. So the dermatographism is usually when you stroke the skin, it will appear. I will show you a picture. Cold urticaria, usually the trigger is cold air or cold water. Cholinergic contact urticaria, usually the patient when they sweat after exercise, after hot water. The clinical clue, usually it's pinpoint wheals, or the patient will say that I have itchiness after sweating, or I have itchiness when I exercise. Delayed pressure urticaria, you would see it in pressure area, like bra area, like the belt area, socks, or when the patient is holding a handbag for a long time. Solar urticaria, from the name, it's related to sun exposure. Heat urticaria related to the heat. Vibration urticaria related to physical stimuli like the vibration. Aquagenic urticaria, it's related to the water. So I can, this is the picture of dermatographism. Usually you can draw in the patient's skin. You will see sharply demarked erythema after stroking the patient's skin. Delayed pressure urticaria, you would see it in pressure area. Cholinergic urticaria, usually pinpoint, and usually after hot bath or exercise after the patient is sweating. So causes of urticaria, as we mentioned, we have two subtypes. In acute urticaria, 50% of the patient or 50% of the causes is idiopathic. We don't know what is the trigger. And then 50% of the patient, we would know the trigger. And 40% of them, it is upper respiratory tract infection. And then 9%, it's usually drug and less likely to be food. In chronic urticaria, 75 is spontaneous urticaria. So it's non-physical, non-vasculitic. And out of those 75, we have 45 idiopathic, we don't know the cause, and 20 autoimmune, usually related to H. pylori gastritis, parasitic infection, or thyroid disease. And then 5% have pseudo-allergic and 5% related to infection. And then 25 of patients with chronic urticaria is the inducible, the subtypes that we mentioned. On both of them, the spontaneous and inducible can coexist. So approach to the patient with urticaria. Urticaria is a clinical diagnosis, no need for biopsy. Usually the patient will present with those edematous lesion. A detailed history and physical examination should be performed. Usually the patient will present with no rash during the visit. So you can show the patient photograph of the urticaria and ask them, is it similar to this lesion? Or you can ask the patient to take a photo and during the next visit to show it to you. But you can make the diagnosis based on the history, like lesions that last less than 24 hours, moves from side to side, itchy, with a swelling, and leaving resolve without leaving any hyperpigmentation. In most cases of chronic urticaria, no external cause can be identified. So as we mentioned, more than 40% is idiopathic. Patients often ask about food allergies. So IgE-mediated food allergies is far more likely to present with acute urticaria. And even in acute urticaria, it's only represent 1% of the cases to present with acute urticaria. A detailed food diary or dietary modification can help identify food or additive that worsen chronic urticaria. So if the patient is suspected to have food allergy, we'll ask him to make a diary or a log of what he's eating, what did he do at that specific day when he developed the urticaria. Important points in history taking. So it's very important to ask about the onset of the symptoms to differentiate between acute and chronic because the management is different. The management is different and the prognosis is different. Frequency and duration of the wheel. How long does it last? Is it less than 24 hours? Is it more than 24 hours? Distribution of the wheels. Is it at the pressure site like bra site, belt site, sac site? This is indicate a delayed pressure urticaria. Is there associated angioedema? Is it itchy or painful? Because pain is more likely to be with urticaria vasculitis. Is there a possible trigger like food, water exposure, weather like sun, heat, exercise, cold, physical stimuli like if you scratch your skin, does the urticaria appear? Vibration, urticaria, does it appear when you in a motorcycle, or does it appear when like any vibratory stimuli? Is it related to your menstrual cycle or pregnancy? Because this indicate that there is a hormonal causes for the urticaria, and we would treat the patient differently. We have to ask about a gastrointestinal issue like gastric upset in H. pylori or abdominal pain in a patient with parasitic infection. Does the patient any allergic to any food or medication? Does the patient have any infection, internal disease, especially thyroid? Patient with atopy have higher risk to have urticaria, so we have to ask about it. And also family history of atopy. Also, this is important in our management, so we will discuss that later. A patient with urticaria who has atopy, usually we prefer some type of medication over the other. And of course, we have to ask about drug history. Okay, should we do lab? Should we investigate further in urticaria? Because we said it's a clinical diagnosis. So what we should do? In acute urticaria, usually no need to do anything, except the patient if he has a strong history of food or drug allergy, we would refer the patient to allergist to perform specific tests like skin prick test or the IgE related blood test. For chronic spontaneous urticaria, those who have recurrent episode of urticaria last more than 6 weeks, we have to do blood investigation. We have to order CBC, CRP to rule out systemic disease, total IgE, and anti-TPO antibody. This is for all the patients with chronic spontaneous urticaria. We consider further investigation based on the clinical presentation. If the patient have gastric upset, we will order H. pylori. If the patient have abdominal pain or signs or symptoms of parasite, we would order stool or ova stool for ova and parasite. So if the patient have physical urticaria, we have a different challenging test based on the trigger, and usually we don't do it in the clinic, but we can ask the patient, as previously mentioned, if it's related to physical activity or not, and then avoid any of those if it's the trigger. So the management, the most important is avoidance. of acute urticaria, usually the trigger would be identified. In chronic spontaneous urticaria, usually the trigger, it's difficult to identify, but we would advise the patient to avoid non-steroidal anti-inflammatory drug, alcohol, or opioids. Usually those medication would exacerbate the chronic spontaneous urticaria, and usually we don't advise the patient to avoid food or diet restriction in chronic spontaneous urticaria. If the patient has a history of anaphylaxis, we have to provide them to EpiPen at home. And usually the anaphylaxis is more common in those who have cold, solar, or exercise-induced urticaria. We have to reassure the patient because in acute urticaria, most of the cases will resolve spontaneously, even in chronic spontaneous urticaria. Usually, the patient will have his symptoms will resolve within 1 year up to 5 years, but some patients will have them for years. So this is how we treat the chronic inducive urticaria. This is the diagram from Pelonia. However, I believe this is an old approach to the treatment of urticaria, and we have changed this treatment, and we have a better approach to the treatment of urticaria. So Pilonia believed that we have to remove we have to identify the cause and avoid it. And then for the pharmacological therapy, we have second generation H1 antihistamine. If there is no improvement, we increase it to four-fold of the second generation antihistamine. If there is little or no response, we would add H2 antagonists or mentally cast, especially for those of angioedema. For the new guideline, they don't believe in adding H2 antagonists or montelukast. The clinical trial have not found that any addition, like adding montelukast or other leukotrienes inhibitor, would add any benefit to urticaria. Then the second line is combination therapy, including doxepin or dapsone, or short course of systemic corticosteroid 0.3 to 0.5 milligram per kg of bread for 10 to 14 days. However, this should be avoided in chronic urticaria, and this should be used for short term and for elevation of symptoms until you consider a long-term therapy. The third line here, Pilonia mentioned that omalizumab is a third line therapy, and then also cyclosporin in severe refractory chronic urticaria. This is what I'm following actually, to start with second generation antihistamine, and if needed, to increase the dose up to 4 weeks, fourfold, and then to assess the response. If there is no response with a higher dose of fourfold within 4 weeks, then move to the second line. My second line of treatment is omalizumab, 300 milligram sub-Q every 4 weeks, and then I can modify the dose if there is no improvement with 300 milligram sub-Q every 4 weeks to 600 milligram every 4 weeks, or also I can modify the dose. The usual dose is 300 milligram every 4 weeks, either to increase the dose to 600 milligram every 4 weeks, or to increase the duration, 300 milligram every 2 weeks. If both increasing the dose and the frequency, there is no response, then I will do both. I will increase to 600 milligram sub-Q every 2 weeks. There is still no improvement, I would move to dupilumab. So we'll discuss it in the next slide. However, some guideline as this one, they add also cyclosporin 2.5 to 5 milligram per kg per day. However, like cyclosporin wouldn't be an option for long-term treatment. So this is the first line therapy. It's antihistamine. which is a second generation H1 blocker. We have cetirizine, disloratadine, fexofenloratadine, and Plexin and Ropal. I believe only we have the loratadine, disloratadine, and cetirizine available in the Saudi market. And then we increase it up to 4 times. If there is no improvement, we will move to the second line therapy. The second line therapy, we have omalizumab or dupilumab. Omalizumab is approved for more than 12 years old. It's usually injection, sub-Q injection every 4 weeks, and we discuss how to increase it. Or dupilumab, which is also approved, recently approved in April 2025 for 12 years or older. Usually, we choose it for those who have atopic dermatitis or prurigo nodularis. So as I mentioned, it's important to ask in the history, does the patient have a family history of atopic dermatitis? Does he has a history of atopic dermatitis? Usually the dose depends on the weight and the age, but it's usually a sub-Q injection every 2 weeks. The third line therapy is combining cyclosporin with second generation H1 antihistamine or combining cyclosporin with omalizumab and dupilumab. There is a new FDA-approved medication, which is a proton tyrosine kinase inhibitor. It's approved in September 2025 for adults, which is a pill taking BID 25 milligram per mouth taking BID. When to consider referral to a dermatologist or allergist, if there is failure or difficulty tolerating first-line treatment, if the patient need for a specialized treatment for if he need omalizumab or dupilumab, if the patient present with severe symptoms that affecting his quality of life. If there is atypical features that the patient having systemic symptoms, or if the lesion lasts more than 24 hours and leaving hyperpigmentation. So we have to take biopsy for this patient and to rule out urticaria vasculitis. So take-home message from the urticaria present with recurrent itchy wheal that have pale center and typically resolve within 24 hours. It may also occur with angioedema. Urticaria is classified as acute, lasting less than 6 hours, chronic lasting 6 hours or longer, which can be spontaneous or inducible. Diagnosis relies primarily on clinical history and physical examination, with diagnostic tests usually used selectively. Second generation non-sedative antihistamine are the first line treatment. Omalizumab and cyclosporin are options for more severe chronic cases. Refer to a dermatologist. Allergist is recommended when first line antihistamine fail or are not tolerated, specialized treatment is needed, or symptoms are severe or atypical. Thank you so much. I hope you learned something and you enjoyed the presentation.
يعطيك العافية دكتورة حصة، وشكرا لك مرة ثانية والله على both lectures. هل ممكن دكتورة we go over the questions for 10 minutes for 5 minutes يعني until يعني if there are questions.